going to have Dr. Lindbergh start with hormonal therapy and speak for about 40 minutes, he promises me. I think you all know that Dr. Lindbergh has been in the community probably 2 or 3 years longer than I have, so that's a long time. And he has been very interested in prostate cancer. For the last several years, he's been exclusively doing prostate cancer 1 or 2 days a week. So he's a true expert in this field, and we will get started with him now.
Okay, so this was not the order we were going to do it in. I was going to sort of clean up and comment on their talks and let you know where I disagreed. However, now they get to totally disprove everything I'm saying, and I'm really sorry about that. And actually what Dr. Lindbergh said I'm going to talk on is not exactly true, but anyway, first slide. Okay, screening trials. She just said that we offer a lot of PSA tests in the community, and that's great. And then you may have heard the headlines, well, PSA screening is not worthwhile. Has anybody ever heard that? Anybody? Well, at least few people have heard. Okay, so the first trial was the USA prostate cancer screening trial. They took men and they followed them for up to 10 years. They reported the results at approximately 7 years. They had a whole mess of men, 76,000. And you could get into the trial if you had no more than 1 PSA done in the previous 3 years. So, like when they did a mammogram screening trial, you wouldn't have had a previous mammogram to get into the screening trial. So right there, you've already sort of confused it a little bit because these people had started screening, many of them, before the trial was done. And then they did do biopsies when the PSA reached 4, and what they showed was PSA screening did not prevent death. So that's the headlines. Now, the important thing is, on that trial, is that half of the men, even though they were in the group who wasn't supposed to be getting PSAs, were still getting PSAs. So it's not a trial of no screening versus screening, it's a trial of more screening or less screening, and what does it mean? I have no idea. I don't think it disproves PSA screening, and I don't think it helps us very much. And you can decide for yourself. Okay, the European trial, lots of men, 162,000. The biopsies for PSA over 3, but except for in Finland, where they biopsied for over 4, and then some of the other countries did a little bit differently too. Well, what did they do? I don't know, I had more on another slide, or what I thought anyway, it doesn't say it here. The point was, what was their screening consisted of? 1 PSA every 4 years. Not every year, but every 4 years. And so they found actually more cancers in the test group than in the control group. So they were diagnosing prostate cancer. There were 214 deaths in the test group, 126 in control, and what was in the New York Times and all the newspapers, whatever, you had to treat 47 men to prevent 1 death. Another way they reported it was a 20 or 25% decrease in the death rate. So, but what really impresses me is that in the control group, they had almost 3,200 men who had cancer in their bone, but only 1,800 who had it in the bone in the guys who got screened. Prostate cancer is a very long-lasting disease. Sometimes you hear 5-year survival means nothing. 10-year survival, a little bit more. 15 years is a better marker. And so these men were being followed up at 8 years. And it's very probable that all the men who had the metastasis will eventually go on maybe to die of prostate cancer, but certainly to be hurt by the bone metastasis. So But the way I conclude is PSA screening, as done in Europe, once every 4 years, will actually clearly, markedly reduce the risk of getting cancer in the bone. And most people would say that's really important. It's not that we can't treat cancer in the bone, but just to say, look at only the survival data, I think is not the right way to look at it. So I still really think PSA screening is great. Well, I mean, I think PSA screening is reasonable. One of the reasons we don't PSA screen is because we know a lot of guys who have prostate cancer get over-treatment, and we're going to talk about that a little bit later. So go to the next one. Well, one other thing I wanted to say, and Pavel, you'll have to tell me if I'm totally wrong about this, but I have heard that the Urology Society, so forth and so on, is recommending a PSA at age 40. Is that correct?
For men who have first-degree relatives with prostate cancer,
Okay.
and for African American men, yes, but
PSA,
for men who have first-degree relatives, that's a brother or brother, with prostate cancer, or for African American men, for the rest of us.
okay, so part of the reason that's such a good thing is the fact that at age 40, you don't have enlargement of the prostate. And enlarged prostate, BPH also reaches PSA and gets you all confused. So a PSA at age 40 is very important. Now, what's the normal? Well, there's a fellow at Cleveland Clinic by the name of Eric Klein that I talked to about this, and he gave me two answers. One was a quick answer that was totally shocking to me, and then he changed his answer and modified it by email a couple of months later when I pushed him on it. So in the meantime, I've written a article for the New Mexico support group on prostate cancer, which was wrong. But he at first, when I talked to him, I said, a man 42 with a PSA of over 1.5. Dr. Klein said, he needs a biopsy. However, in his modified statement, what he told me was that man who has a PSA over 1.5, whose family history of prostate cancer, that such a person should be watched closely, and if the PSA is rising, you ought to biopsy sooner rather than later. And so this is totally, I think it's probably new news to everybody here, other than Pavel, and he might talk about it later, but so that's it on screening. Now, okay, so what about prevention? So a real close friend of mine said, I said, you ought to come tonight. And this friend of mine is about 50. And he says, well, he said, my father has prostate cancer, so he'd be real interested in coming. I said, well, why aren't you coming? Well, I said, well, you're the one that needs to come. Because he's the one that's at risk, and maybe we can prevent prostate cancer. And so here's the prevention trial. One used finasteride, one used Avodart, and it did reduce prostate cancer risk by 25%. That next statement says that doctors, if you're undergoing screening and you're over 55, doctors are supposed to talk to their patients about the possibility of taking Proscar or finasteride to reduce the risk. Go ahead, next one. Now, Dr. Walsh in the New England Journal of Medicine, Dr. Walsh is the ultimate guru. He knows everything, and he tells everybody what to do. And you don't cross Dr. Walsh. And you don't, absolutely. However, and so he said we shouldn't use these drugs. And then I contacted Dr. Klein at the Cleveland Clinic, and there it says, I disagree with Pat, they're on first name basis, that either agent is dangerous. And he said that this, 90% of the men, this is true. Men come in, they've got prostate cancer, it's low risk, and we still treat them. But we're worried that we're over-treating some of these guys, that we're subjecting them to complications of treatment. And so, if you had an agent that would cut the risk of prostate cancer down by 25%, you're going to really reduce unnecessary treatment. That's what I think. So I think the family history of prostate cancer, watch it more closely and consider the possibility of taking Prostate. You can say a different opinion later on. Your slides weren't ready. Go ahead and talk now.
No, I wasn't planning to talk about chemoprevention in my presentation. I was going to talk about surgery, but from what I've read and from what I've seen, I did not find any evidence that there's any harm in it. Neither did I find any evidence
That there's no harm.
Well, I did not find any evidence that there is harm, but I did not find any evidence that there was a definite benefit.
Okay.
Even that the drugs are very benign and very well tolerated, and inexpensive to use generic finasteride, one can make an argument that until we figure out better, we may give it the benefit of the doubt and just do it. And if you have no side effects, there's no harm done. I don't think there's a final determination as to whether or not chemoprevention works.
Yeah. So I think that I would say what works and say, well, so we disagree on that, and that's fine, but I still think it's reasonable to do. Now, should I shut up?
I think it doesn't hurt.
Yeah.
So we don't disagree as much.
Pardon? Well, did you want to then go do those guys, and I'll get into other parts later, or not? Okay, so here's something that is relatively new. And I'll just throw this in with diet. Everybody's very interested in diet. Oh, we can do this with diet and so forth. A lot of the stuff that you hear about diet is not proven. It's anecdotal, it's retrospective, etc. Well, there are 5 studies showing that having a cholesterol level, that your cholesterol didn't change whether you're going to get prostate cancer, but all these studies show there's a lower risk of getting the bad kind of fatal prostate cancer. And so, next slide. Well, that slide doesn't exist, so here's what I wanted to say.
This is actually in their pamphlets.
Oh. Well, anyway, here's the point. Not on this slide. But as far as cholesterol goes, there was a prostate cancer prevention trial, and that had a large number of men. And that's the trial that they thought showed a 25% reduction in the rate of prostate cancer. But then they've looked back at that. They have cholesterols measured in these men, and this is a prospective study, which really makes sense. And so they could show that men who had a cholesterol under 200 had about a 60% lower risk of developing really bad prostate cancer. So if you have to take a statin drug for your heart, this is just one probable added extra benefit. And I really think it makes sense, and I consider this really solid. I'll just mention diet. There's a lot of excitement about selenium. There's a lot of excitement about vitamin E. Anybody here taking selenium to prevent prostate cancer? Okay, it's now been absolutely proven it doesn't work. There's a huge study, and we got the numbers, and it does not prevent prostate cancer. And they gave it selenium alone, selenium with vitamin E alone, and in none of that could they show any benefit to taking selenium, despite what's been said, despite what's been previously published. Now, this is in your folder. And, well, it doesn't come up. It's pretty, well, I guess we can see it here. Forget the top 2. Gleason 2 to 4, Gleason 5. Because this category does not exist, essentially. We don't really see that up here, like Gleason 2 to 4. And Gleason 5 is really rare. So most people with well-differentiated prostate cancer have this group. And this is really, to me, interesting. Shows if you've got a Gleason score of 6, at 15 years, you have maybe a 25% chance of dying of prostate cancer. If at the time of diagnosis back here you were 65, about 25% here at Gleason 6. But even if you get prostate cancer, you're still, this right down here, you're very likely to die of other things. When you get to Gleason 7, and say you're 55 years old, there's a pretty good chance you could die of prostate cancer. None of these men were treated. This is just following these people for 15 years. Now, this was studies that reflect what was going on from, say, 1960 to 1980. And again, Gleason score 8 to 10. If you're 60 years old and don't get treated, there's about an 80% chance you're going to die of prostate cancer. So next, let's go to the next slide. Well, this is just how you stage prostate cancer. And this is really important because it turns out that all prostate cancer is the same. This whole thing gets confusing. And it's not like a lot of the other cancers. Most breast cancer, if you've got it and you don't treat it, you're going to die of it. It's really very dangerous. But there's a bunch of people, for sure, that the chance of dying of it is really low. So here's a low risk of cancer. Gleason score just means how it looks under the microscope. So if your Gleason score is 6 and your PSA is under 10 and there's no lump or small lump, you have a really good outlook. And a lot of things really can help. Surgery, radiation, seeds, everything works. Intermediate risk, this is a much more dangerous cancer. So this is Gleason 7, PSA more than 10, a fairly big lump, and then this is the high risk category down here. Let's go to the next slide. When we looked at active surveillance again, and this was an updated, that big slide showing what happens to people, it turned out that for men who we were probably diagnosing these men earlier because this is now in the PSA era. And before, when we talked about prostate cancer, you diagnosed it by feeling a lump. But these men, it included younger men too, who had intermediate risk prostate cancer, still, chance of dying with no treatment was only 6%. Next. So, Dr. Klotz up in Canada, at the Mayo Clinic, they enrolled a lot of men with low-risk cancer and just watched them. And now, with about 7 years overall follow-up, they've been doing this for 15 years, 97% are still alive in the whole group. But 40% or 30% had changed and were now given surgery or radiation. And of the men who then were operated or given radiation, out of that 30%, 15% were not cured. And even though they were not cured, they still had an 18 times greater risk of dying from another cause. So this is why we talk about active surveillance. And active surveillance isn't making the diagnosis and then go see your doctor again in 5 years. We've seen that's how it used to be done. So the other thing is, in the Klotz study, about 30% had Gleason 7. In a Klotz study, they had a lot of cancer, up to 30% involvement, and so forth. Now, sort of when somebody comes in and talks to me about active surveillance and not giving treatment, no treatment, well, I don't like more than 2 cores positive, no lump or small lump. I'd like to get a national expert to review it, because sometimes pathologists who are not by doing that, sometimes it changes the diagnosis. And recently I went through some of my results, and out of about 50 patients, there were about 3 were doing getting a second opinion from the pathologist really made a difference and changed the Gleason score. And, doubling time longer than 3 years is important, because if your PSA is going from 2 to 4 in 1 year, you're not a candidate for active surveillance. You should have surgery or radiation or active treatment. And then there's one other thing I just found out today, and I talked to a bunch of people today, and I think I got the answer, and then I went back to my file, and it seems like I had something from 5 years ago that I kind of ignored. But anyway, there's a marker called Ki-67, and this tells us how fast the cells are dividing, or can. Now the local pathologist says, boy, that's a very subjective test. They don't think it's too good. I've never used it. Well, anyway, I did call up Dr. Bostwick at the Bostwick Laboratories because there had been a study done that I heard about or saw at my cancer meeting in San Francisco, prostate cancer meeting, where they said that in men who had their radical prostatectomy, they looked at the specimen, and if the cells were dividing rapidly, those guys had a much higher chance of dying. And they used the KI67 test. Well, I was wondering whether the small amount of tissue we have when you do a biopsy, and you have just a teeny weeny little bit, is that enough to do this on? And according to Bostwick's lab, they can do this test, and it might help us. And if I did this on, I haven't ever done this, but if you do it now, maybe we could find those men who really shouldn't be watched. Everything else was fine, but their cells were dividing rapidly, and that person should go ahead and get treatment. And then, of course, we do follow the PSAs every 3 to 4 months, so not once every 5 years. We do a rectal exam at least 3 times a year, and probably repeat the biopsy in 1 year or 3 years.
Thank you, Dr. Lindberg. We are going to have a panel discussion at the end, so please save your questions for the speakers, because they'll be up here on the stage arguing with each other. As you can tell, this is not a written in stone topic. And for those of you who came to a prostate cancer seminar about 4 or 5 years ago that this group put on, the speaker from the University of Mexico Medical School was showing you data on selenium and its treatment of prostate cancer and prevention. So it's interesting how times we keep learning things. Our next speaker then is going to be Dr. Pablo Morachov, who is one of our surgeons, urologist here at Los Alamos. Dr. Morachov comes to us originally from Russia and then trained in the United States. And he has been doing prostate surgery for quite some time, and hopefully our slides will work and we'll be able to have his presentation. Just a comment for the nurses who want CME credits for this program. In your packet, there's a sheet that you have to fill out and give it to the people at the desk in the back. So, and then after Dr. Morachov's talk, we're going to take a short break, 10-minute break, and then we'll resume with the program. So, Dr. Morachov?
Good evening. Thank you for coming. I am going to talk about prostate cancer from a surgeon's perspective. Next slide. I will talk about conventional prostatectomy and its role in today's treatment of prostate cancer. I'm sure many of you have heard about so-called robotic surgery or robotic-assisted laparoscopic prostatectomy. I'm going to talk about that as well. And then I will talk about prior therapy and its role in prostate cancer. Next slide. So the goals of surgical treatment, as with any definitive form of therapy, is to achieve cancer control with preservation of urinary continence and preservation of sexual potency in those who desire that and who are potent at the time, while trying to minimize the rates of short and long-term complications and morbidity of treatment. Next slide. Radical retropubic prostatectomy has been considered a gold standard of treatment for prostate cancer for the last, I would say, 20 to 30 years. It's a procedure that was pioneered by the same Patrick Walsh that Dr. Lindberg mentioned, that you got to not cross. And before Dr. Walsh's redesign, so to speak, of the prostatectomy, it used to be a sort of disastrously bloody operation that left most men incontinent and impotent, and would not be unusual to have 2 liter or more blood loss to it. So what he did was to study the anatomy of the neurovascular structures of the prostate in great detail and design the operation around better understanding of this anatomy. Next paragraph. Next slide. This is kind of a busy slide. It's that shows anatomy of the prostate, and as we know, prostate sits between the bladder and the urethra. Most of what he did was a lot of cadaveric dissection, where he identified the neural bundles coursing alongside the prostate at about 3 and 9 o'clock, and also to identify a large vein that runs on top of the prostate, and if divided early, allows better visualization and dissection at the sphincter so that the sphincter is not damaged. So the two biggest advantages were preservation of nerves and preservation of the sphincter through better vascular control during the surgery. Next slide. Essentially, this is what I just mentioned, and again, preserving neurovascular bundles of the prostate helps preserve potency, and preserving the external sphincter helps keep me uncontinent. At the best of hands, and this is something I'm going to talk about later, this procedure takes about 2 hours. The blood loss of up to 1,000 cc's is not unusual in the way the operation is carried. That is geared towards losing blood but preserving blood supply and nerve supply that allows men to keep potency. This is not something that is dramatic, because usually this operation is done in healthy men who can tolerate substantial blood loss, and transfusions are almost never done following a radical prostatectomy. Hospitalizations, usually 2 to 3 days. Patients have a catheter for about 1 or 2 weeks, depending on who you ask. Return to normal activity, and by that I mean not just being able to go back to work and sit at the desk, but feeling completely up to your previous self as far as feeling of wellness, strength, energy. Usually takes about 4 weeks. Return of potency and continence after surgery may take up to 6 to 12 months, but in some patients, return of continence is immediate. Return of potency almost always takes a little bit of time, but when I counsel patients after prostatectomy and before prostatectomy as to what to expect, I usually tell them that you will be as you are at 1 year out, and until then things may and will continue to improve. Next slide. The outcomes of radical prostatectomy, and this is all comers, and it involves people with different risk factors, as Dr. Lindberg was mentioning, different risk groups. Altogether, cancer control of about 80%, potency preservation, depending on whose numbers you look, are 30 to 70%, and this largely depends on the age and health before surgery. Continence rates of 90 to 95%, and all of these are affected by the cancer grade, cancer stage, the size of the prostate, body happiness of the patient, because larger obese patients make for more difficult surgery and tend to have worse outcomes, and as I mentioned, preoperative sexual function. Laparoscopic prostatectomy was kind of a bridge technology where people try doing this operation, say, the same way most gallbladders are removed nowadays, with a number of small incisions, a video camera and a telescope, and several stick-like instruments. And this was tried in Germany first, and then there was a big series by these 2 French surgeons at one particular institution in France, where they did over 1,000 of these procedures. And the bottom line on this operation is that it's extremely difficult technically. At the very best surgeons, and you could probably count the number of people who could do this operation well on probably fingers of 2 hands. At best, they achieved similar results to the open procedure, and there really wasn't any significant benefit. So this thing was tried but never did. Robotic assisted prostatectomy is the way that 75 to 80% of prostatectomies are done nowadays. It's a very interesting phenomenon. It was initially performed on a platform called Zeus, which evolved from an abandoned DARPA project where they were interested in designing a remotely operated field surgical unit that, say, you could have a medic stick a number of manipulators into a critically injured patient in the field and then have a surgeon elsewhere remotely control the device. They very rapidly abandoned it because the device was extremely cumbersome and it was not worthwhile. It was more worthwhile to get patients stabilized and transported. But some of the technology was developed that then was improved upon by Intuitive Surgical, including the Da Vinci surgical system that was approved by FDA in the year 2000. The system itself evolved through several generations with higher definition video and better quality manipulators, and ultimately this technology exploded. I just read something today where the numbers were that there's about 1,400 of these devices now worldwide, and about 1,100 of them are, of course, in the US. Next paragraph. Unfortunately, this video will not play, so we will not see. So the truth and fiction about robotic prostatectomy, this is something that is being very actively advertised by institutions who purchase these devices, and I will go into reasons why. But there are certain claims that are made about this. One is there are smaller incisions. It is probably true. You have 5 or 6 incisions, each of which half an inch to an inch in size. If you add them all together, it's probably 1/2 of a standard prostatectomy incision that is about 7 to 10 inches in length. Whether cosmetic outcomes of this type matter to men who undergo this procedure is questionable, but this claim happens to be true. Faster return to normal activity is claimed, and this is something that I mentioned before, is how long it takes for a patient from the time he had surgery to, say, go back to shoveling hay and sort of not getting too tired after that. And that time is indeed shorter. It is probably about 2 weeks. Again, how significant is this for the person shoveling hay or for a person sitting at the desk is another question, because it comes at a very steep price. Shorter hospital stays are claimed that is indeed true, but the difference in hospital stay lengths is on average 1 day. The claim of comparable operative times is probably true with a very highly trained OR team that is skillful at setting up the device. This operation can be done in about 2.5 hours, which is about the time a good surgeon could do radical prostatectomy. Again, this in good hands with a good team in a place with high volume. I have seen this done in 2 hours. I've also seen this done in 7. The other claims, less pain because the incisions are smaller, the narcotic use was compared and no meaningful differences were found. Less blood loss, same thing. There were no statistically significant differences. The initial thinking was because the device allows much better visualization of the prostate and neurovascular structures, which is indeed true, because the camera there is a 10x stereoscopic microscope, essentially, and we were doing this operation. It's very nice. You can actually see all the structures. The initial expectation was that there will be better cancer control, there will be better preservation of potency, and better preservation of continence, and unfortunately, none of this turned to be true. The biggest issue with the robotic surgery is economics. The company that's selling it is doing extremely well. They're a monopolist in the market, and they get away with other things. They turned out about $750 million profit last year. And that's why. The robot costs about $1.5 million. They also require a service contract with the hospital that ranges about $150,000 to $200,000 per year, plus the cost of disposable equipment for each case goes between $1,500 and $2,000, depending on the surgery. Also, for this to function in any meaningful fashion, you need a very highly trained, dedicated OR team that knows how to set up the device, how to what's called the docket, that is to connect the manipulators to the robot, and it makes a tremendous difference in how these cases go. So the arguments as to how much this costs are ongoing, because obviously there are interested parties that are trying to get hospitals to buy this stuff, and so they try to make numbers look better. This is just one study, and they looked at 1 year cost. No, actually, I think they looked at the procedural cost of a robotic prostatectomy. This was done last year in a particular institution, and they found that the conventional surgery cost about $17,000, the robotic surgery costs about $25,000, Medicare in that state pays about $17,000. So in each of these cases, the hospital loses about $8,000. But there are factors affecting cost, and all analysis shown that for an institution to make money off of this, it needs to be a factory. So there are places that do hundreds of these per year, and there it makes financial sense, otherwise it doesn't. Early in the learning curve, the case take longer, and they're more expensive, but the biggest determinant of cost efficiency of this treatment is case load. Next slide. So the bottom line is that this is sort of a paradoxical situation. We have a new operation that's gaining popularity and is done more and more to a point again, but I think it was reported to be that 80% of all prostatectomies today are done with the use of a robot, despite the fact that the benefits have shown to be marginal. But this is both patient and industry driven.
When you're done on that point, I'd like to just say about forwards to totally agree with you.
Absolutely. So this is both patient and industry driven, because this is probably the most advertised medical procedure in the, surgical procedure in the history of surgery. And I've seen pictures of billboards at stadiums showing doctors how, that they do robotic prostatectomies, and so patients are led to believe that this is better. The industry, on the other hand, goes and harasses the hospitals by saying that, if hospital A has it, and you being hospital B don't have it, you lose prestige and you lose patients for other procedures by the fact that you're not cool enough and you don't have a robot, because they can't really sell it on the basis that you're going to buy this $2 million device and make money. They sell it in sort of the Jones factor. So if you want to be better than the Joneses, you go buy a robot. So there's one city in St. Vincent, and I'm not sure there's a urologist working on it, but there's a lot of them. Again, the biggest things to consider in choosing surgery for prostate cancer is that there is power in numbers. And it's been shown for many varieties of repetitive surgeries like cardiac surgery, open prostate surgery, and to some extent this is true for robotic surgery, is that the high case volume surgeons and centers tend to get better results. So if anybody does, say like Pat Walsh in his better days, a couple of hundred or more radical prostatectomies per year, or say the doc I watched working in Philadelphia who does probably 300 to 400 of these robotically a year, they will have better results than people who do 5 or 10. And this will remain true for, again, this has been shown for cardiac surgery, it's true for prostate surgery. So the power of numbers works. However, there's another side to numbers, is that you have to be aware of numbers. Patrick Walsh got very good results that were better than most others by selecting young, healthy, potent, low-risk patients under the age of 60 and operating only on them. And so there's people whose numbers look better, but you have to see how they've gotten them. And there's nothing necessarily wrong with that, because there's many people who can do this operation, but this is how he did that, and he achieved excellent results with his patients. Another thing about this operation, it's probably easier to learn for an average surgeon with some laparoscopic training than an open prostatectomy. Open prostatectomy is a difficult operation, it's really challenging. And so if somebody were to do, say, not too many of these per year, it's probably better to do them in a robot than to do them open. And that's been an argument that for surgeons who do less than, say, 50 of these per year, you probably probably better off to do it on the robot when we know how, even though it does not make financial sense for an institution. So it is here to stay. Hopefully the equipment will evolve and become better, and then hopefully there will be competition that will make this more affordable. So this is a good technology, sort of still in development. That's something good will come out of it, and it's interesting to watch.
So I agree with everything that he said. I just want to emphasize one thing, and that is it sounds so great. And a man has prostate cancer, and the first thing is, I'm thinking of the robot. And to me, I didn't know anything about it about 4 or 5 years ago, so I checked into it. To me, you want to cure the cancer, you'd like to be potent, and you would like to not leak urine. And this stuff sounds like it's all so much better. And it's just not true. They do have no data showing that this is any better than a standard radical prostatectomy. And yet it's advertised and advertised and advertised. And I talked to a fellow the other day from Albuquerque, and he's in the legal profession. He says, I'm thinking of the robot, but they told me I couldn't have it at UNM, blah, blah, blah. And I said, well, I'm not. I don't, we ought to talk a little bit about that. So he said, well, my best friend went to Colorado and had the robot, and his was a disaster. It had all sorts of complications. Nevertheless, knowing that, this guy says, I'm thinking of the robot. So I've written also the Prostate Cancer Support Group about this and sort of blasted it, because that really is heavily, heavily, heavily advertised, and it's a wonder miracle procedure, and I think everything Pavel said about it is absolutely correct.
Thank you. Well, one thing I didn't say about that, however, having done a few of them, where I came from in Pittsburgh, it is the best video game ever. So, I see the allure of using it, but I agree with the clinical outcome. Second thing I'm going to talk about is cryotherapy, which is a completely different modality of treating prostate cancer that I will say from the get-go, I am more in favor of than surgery as far as outcomes go. This is a procedure that evolved dramatically in the last 30 years or so. It was initially used for salvage of failed radiation treatments, mostly. And at the time, it involved using cryoprobes, running liquid nitrogen in them that were a little bit smaller than the diameter of a pencil. So they had to be placed through incisions. The monitoring was not accurate. There were terrible complications afterwards. I'd say 30% of patients developed a leak of urine in the rectum, incontinence, sloughing of the urethra, which was painful and annoying. So initially this therapy got a really bad rap, and Dr. Patrick Walsh, whom you must not never cross, kind of spearheaded the movement against it and is still very down on it. Next. It evolved dramatically with a modern generation cryoprobes that was developed by Galil, the Israeli weapon maker, initially to cool the heat-seeking element in the missiles. And nowadays, the probes are needles at about 2 millimeters in diameter. They're powered by running compressed argon through them to cool them down, and so they can be inserted without cutting the skin. The technique is very similar to brachytherapy. There's real-time ultrasonic monitoring, there's temperature monitoring, the key areas that being the sphincter, the rectum, and in case of nerve-sparing procedures I'll talk about later, the neurovascular bundles. There's also a urethral warming device that prevents urethral sloughing. Next. So the device presently is made, unfortunately, by only one company who acquired the wheel. It's called EndoCare. It's this computer-controlled console that feeds ultrasound into it and provides a calculation of where the needles are to be placed, which some surgeons use as a suggestion. I usually do it by eye. These are the needles. When they're tested, they are usually submerged in water, and you see the water water freezing on them, and you see they're pretty small. And then there's a urethral warmer that controls the temperature of the urethra and measures it and runs warm solution through it so that the urethra does not freeze, which is key to not having painful voiding symptoms afterwards. Next slide. Again, the setup of the procedure for those familiar with brachytherapy is essentially identical. The patient goes to sleep. He's put in stirrups in what's called the dorsal lithotomy position. There's an ultrasound probe inserted in the rectum that allows to see the prostate, and I'll show some pictures of that later. Then the needles are inserted, and they essentially allow freezing of the entire prostate without damaging surrounding organs. Next slide. So it begins with the ultrasound. This is the prostate as is seen on ultrasound on this device. It's measured, and then the calculation is made how many probes to use and where. Next slide. Then the probes are placed again for people seeing brachytherapy. It's identical. You can see them as these sort of lines. And so all of this done with extreme precision. The resolution of this scanner is 7 millimeters. So you can really see where you're putting the probes. Next. And then you watch the ice form in real time. And this is a picture of the prostate in longitudinal direction. So you're looking at it lengthwise, and you are looking at the edge of ice wall, and this is the wall of the rectum. So you can really control the extent of freezing, again, with 7 millimeter precision in real time, in addition to having thermocouples that monitor temperature in critical areas. Next one. The results, operative times are about an hour and a half. It's either a same day or an overnight stay procedure, depending on the surgeon's sense of adventure and the patient's desire. The return to normal is essentially immediate. The only thing that takes a while is for the swelling of the prostate to subside and normal urination to resume, and so these patients usually go home with a small suprapubic catheter. They can open up to drainage periodically, and so when they come back, they can tell me if they're voiding or not, and then the catheter is removed. Both from literature and from personal experience, the patient satisfaction from this procedure is very good. Next. The cancer control and side effects. From the data that's been out so far, there's a similar 80% 5-year cancer control as you can find with surgery or other treatment modalities. The rates of serious morbidity like incontinence or rectal injury nowadays with the modern technology is less than 1%. An added benefit of this procedure is that improves voiding in patients who have BPH. But the truth of the matter is that the rates of incontinence following this procedure, as it's done in the conventional fashion, is, according to literature, over 50% or over. When I counsel patients, I tell them that for all practical purposes, it is 100%. And so if you have cryotherapy, you will be impotent if you were potent. If it matters, this is not a treatment for you. But the literature says 50. I tend to take it with a grain of salt. Conclusions on this one, it's a very good minimally invasive procedure that's comparable to others. And in my opinion, this is a procedure of choice in a patient who is either impotent or does not desire to remain potent. Next. Say a few words about subtotal cryoablation, which I think is an extremely interesting emerging therapy for low-risk prostate cancers. And it's based on a theory that 80% of all early-stage cancers, that is cancers found by biopsy and elevated PSA, but without a nodule, are located only in one spot in the prostate. And this is based on people looking at the prostatectomy specimens sliced in many areas to see if the cancer is what's called multifocal or unifocal. So, and there's some argument to this, but based on the idea that most cancers are in one spot, if a patient has, say, 1 or 2 pores on the biopsy on one side only, you could consider doing this subtotal, or some people call it focal cryoablation, with the extent of treatment varying from just that one spot to half of the prostate to say 3/4 of the prostate with preserving one of the neurovascular bundles. Idea being that then we will kill the spot with the cancer without treating the entire prostate, get all the benefits of cryotherapy as far as morbidity goes, but achieve preservation of potency. Next slide. This demonstrates how this procedure is done. So this patient had an MRI of the prostate that showed the cancer to be localized there. This was confirmed by biopsy. This is the spot in question. So this particular surgeon froze just one area of the prostate and left the rest of it intact. And you can see this is the ice ball there. Next. The data of it is still, and it is still young. This is the only reasonable longitudinal study so far. It's compiled from about 340 patients who had subtotal cryotherapy. The upper graph shows return to potency over the course of 48 months, and it is shown to be up to 80%, and the other one shows the biochemical recurrence-free survival at up to 48 months, which is at 80%. This is a very limited study because the data was compiled by the manufacturer of the device in 2 years, regardless of their PSA levels. Definitely very low threshold for repeating biopsy if PSA is rising. Again, it has all benefits of conventional cryotherapy without impotence, and is definitely, in my opinion, better than watchful waiting because you risk almost nothing, you lose almost nothing. If it fails, you can do a salvage therapy with radiation. So again, I'm hopeful that there will be more conclusive information and we'll use it more widely because it's really benign. Next. I think this is it. That's it for my presentation.
Okay, our next speaker is Dr. Calvin Hahn, who is a radiation therapist from Santa Fe. Dr. Hahn has treated many of our patients with external beam radiation therapy, and he came to Santa Fe about 3 years ago, had some outstanding training both at Mass General and Harvard. And so we're delighted to have him here tonight to be able to tell us about radiation therapy. Dr. Hahn?
Thank you, Dr. Lambert. First, I'd like to thank Dr. Lambert and Dr. Marshall for inviting me. I've been in Santa Fe for about 3 years, and before that, I was at University of Washington, and I did my fellowship at Mass General Hospital, and my proton beam fellowship at the Alamos cyclotron before it was demolished a couple years after that. Some of my professors from up there have been to Los Alamos, and when Los Alamos had the Pioneer project, some of them are here looking into the particle beam. So I do have some familiarity with the particle beam. Right now there's a lot of there's an arms race going on in proton beam radiation therapy, and I'll show you some slides and I'll talk a little bit more about it. These machines cost about $150 to $200 million, and there's about 5 centers right now. And when I did my fellowship in 96-7, Loma Linda and Mass General are the only 2 places that has the proton beam. But now we have 5 operating proton beam, and there's another close to 7 or 8 that are planned or in construction right now. So next slide, please. So can we go to the next slide? I'm at St. Vincent Hospital, and I work with Dr. Shina. Some of you might know Dr. Shina. And Dr. Shina's been there for about 8 years. And I'm also part of the urology group down in El Paso. I've worked with 11 urologists, and I'm the radiation oncologist there. So I fly back and forth between Santa Fe and El Paso, and I've been doing that since I've been in Santa Fe. And because I do work with a lot of urologists, I do get to see a lot of prostate cancer patients. Next. And this is my little plane that gets me there. One of my hobbies is flying. So with this little plane, I can get there about an hour and 15 minutes. If I take a...
Is that a jet?
No, it's... no, they don't pay radiation oncologists that much. And this is my wife. She's an internist at Santa Fe. Next slide. Well, the first slide is from the ACS, American Cancer Society. It's a 2006 estimate of U.S. cancer cases in the States, and prostate cancer ranks as number one cancer in men, and overall there are about 720,000 cases per year. In 2006, it's the third most lethal cancer. And for 2009, the estimate is that about 192,000 cases of prostate cancer will be diagnosed, and about 27,000 men will die of prostate cancer. The number that you see a lot is 1 in 6 men will be diagnosed with prostate cancer, but only about 15% of them will die from prostate cancer. So 85% will survive with prostate cancer. And this is the Sears capture data. And the capture data came from the organization out of UCSF, which were looking at the pattern of care in private practice. And what they wanted to do was they wanted to see what procedures are being used to treat early stage prostate cancer. And in community, when it first started, it was mostly the community-based practice from the Bay Area. And radical prostatectomy was the most common curative treatment in the United States. And external beam RT with photon is the second most common treatment in the US. Brachytherapy increased from about 10% in 1990s to about 20% in the 2000s. But it's dropped down again because the CMS really cut the payment on the brachytherapy. And the proton beam is the least common treatment because there's only a few centers in the US. So this slide just shows the incidence by race. American Asian and Alaska Natives has the lowest incidence, and African Americans has the highest incidence.
Could you move to the other side?
I'm sorry. The problem with prostate cancer is that we have a pretty good handle on how to treat prostate cancer. The surgery has improved remarkably in terms of morbidity and toxicity, and same goes with the radiation therapy. But we still don't have a handle on which men should undergo treatment. Because like I showed in the previous slides, although the incidence is pretty high, the lethality from localized prostate cancer is pretty low. And go back. And one of the tools that we use in figuring out how aggressive cancer is going to be is the what we call the TNM stage, tumor node metastasis stage. And this system was first used in France in the 1960s, and then it became popular because in almost all the tumors, the TNM stage determines the prognosis or how aggressive the cancer is going to be, and that goes for prostate as well as lung, as well as breast, or other type of tumor. And then the second prognostic indicator that we use is Gleason score. Gleason score was developed by Dr. Gleason, who was a VA pathologist from Minneapolis. And in 1960s, the chief of urology there wanted a system that can easily, pathologic system that can easily predict which prostate tumors are going to be an aggressive tumor and which are going to be a low-grade tumor.
But here's the deal. So I said that if you have a low-risk prostate cancer, there's a lot of treatment, and most of it really works well, and we have to be sure that we're not over-treating. So the intermediate risk, which is basically Gleason 7, still many things work. A few years ago, Dr. D'Amico from Harvard, this was in 2004, he looked over his risk factors, high, intermediate, low risk. And he looked at 7,700 cases of prostate cancer from around the country, 44 centers. And what happened to those people? And he showed that if you had low risk, you did very well. If you had intermediate risk, you did pretty well. If you only had one factor positive for intermediate risk. So, if your Gleason score is 7, but your PSA is low and you don't have a big lump, you do fine. On the other hand, if you have a PSA of 15 and a Gleason score of 7, you don't do so well. And his conclusion in the study was that we need combination therapy for people with high-risk cancer. That's a Gleason 8, 9, or 10. This is how it looks under the microscope. It's really bad cancer. And we need combination. He said combination maybe for a high intermediate risk of cancer. So he then has subsequently published his paper. And of 200 men, half of them got hormones plus radiation, and the dose of radiation was low, and the other half got just radiation alone. And the results were dramatically different with at least half of the patients who got just radiation alone in this high risk or intermediate risk group that he treated. Half of them had recurred within about 4 years as far as a PSA came back, so they weren't cured. About 80% of guys who got hormones and radiation still had their cancer control. And the way it worked out is that with about 8 years of follow-up, it's very statistically significant, better survival when they got hormones and radiation for 6 months versus just radiation. And so I think the deaths were 14 out of 100 versus 4 from prostate cancer in the group that got the hormones. The overall death rate was clearly, overall survival was clearly better as well. So hormones and radiation are really good. So I've been doing, that was the second part, so I've been doing hormones and radiation for high-risk patients. We're talking 8, 9, and 10, or Gleason 7s. And I have 53 patients like that. I treated them very similar to how Dr. D'Amico treated them, except I used my magic formula, which we haven't had a chance to see tonight, but it's really truly magic. And I used my magic formula with the radiation therapy. And so out of 53 guys, 3 have had a failure. Now, one man died right away. He died within 3 years. We could never get anything controlled on him. He died. The second guy just didn't take his medicines. I'm still seeing him. He's still living. He just didn't sort of bother taking a lot of the time. And the third guy failed, and I have no idea why. So out of that group, about 25 were high risk, about 25 were intermediate, or 24 intermediate risk, and I actually treated 5 lower risk patients, which I probably won't do now, except for these are guys with very extensive disease. So those results are great, but that's just how I did it. Now, I also know there's another, if you look in the literature, you'll find most people will say, oh, you got to treat for 2 or 3 years if you're high risk, right? You've heard that. You know that. Absolutely. Okay, so that study comes from Europe. And in that study, there were, I don't know how many men, 300 men or so. Fine. So this was what they did in that particular study, this is the second Ebola trial, they treated them for 6 months, or they treated them for 3 years. And the 3 years had fewer deaths. And so the conclusion was that proves that for high-risk prostate cancer, you got to treat for 3 years of hormones. And I only treat for a year. Well, gee whiz. The point is, and this is in the letters to the editor of the New England Journal, that 70% of the guys in the European trial had lots worse cancer than we're treating in this country. So they had big, bulky disease. And maybe for those guys, yeah, but most high-risk patients in this country just have maybe a high PSA or they have a high Gleason score. And so Dr. Bola wrote, said, well, basically in the United States, with your kind of patients, it's okay to treat for 6 months. I have a lot more to say.
I agree with Dr. Lindbergh completely. I think in the States, in the PSA era, patients are getting PSA more often in earlier stages than in Europe. And the Scandinavian study, I don't know if you read the Scandinavian study from Denmark, Iceland, looking at surgery versus surveillance. And that was the first randomized study that showed that survival advantage for surgery. But what they...
Oh, yeah, sure. Okay.
Yeah. And what that study, in that study, if you look at their prostate patient population, just like other European studies, they have, even though they have localized disease, they have more patients who are with palpable nodules, they have more patients with lower tract obstructive symptoms. So what the urologists and radiation oncologists know is that over there, their patient population when they're first detected tend to have a bit more advanced disease than the patients here, even though they're sort of early stage.
Today, the FDA approved Provenge, which is immunotherapy for prostate.
Say that again.
Provenge.
What about it?
The FDA approved.
They did today approve it?
Yes.
Wonderful. Okay, so one of my patients, about a week ago says, how come you haven't told me about Provenge before? Well, because we've been waiting for about 3 or 4 years for this thing to be approved. And I saw on, he also sent me saying CBS said it's going to be approved this week maybe. So here's the deal. Provenge, that was one of my slides you didn't get to see, but nevertheless, Provenge is, what it is you take the man's blood and separate all the white cells. And then you send that blood up to probably Seattle. And then they incubate it with what's called a fusion protein. And this protein is prostatic acid phosphatase protein, and it's also a protein called GM-CSF, which stimulates the immune system. And then you put those cells with the white cells, you put it in with that protein and incubate it, and then after that's done, let it cook, then you send it back, and the patients are given about 4 treatments. The side effects are not great because you're really getting your own cells back, not somebody else's cells. You already have these, so you might get a tiny little fever and a little bit of fatigue. The side effects are absolutely minimal. Now, that's $71,000, maybe, but that's not so important. What's really important
per year?
No, so what's really important is, well, how does it work? I mean, people have been asking about vaccine trials forever. Well, this trial then, what it showed was that at 3 years, approximately 33% of the men who were put on the trial, who got the vaccine, such as it is, these men, 33% of them were still alive. Well, that means, whatever, 60 plus that died. In the group who got the control group, those guys about 25% of them were dead. So when you hear fabulous vaccine, we can't wait to get it, well, it does show definitely a survival advantage. There's another trial from Harvard of a pox virus vaccine that also shows delayed improvement in survival. When they tot it all up, they say, well, people who get the vaccine live 4 months longer. 4 months on average. So, that doesn't sound quite as good as maybe it sounded in the headlines, but in addition to that, the people who got it weren't people who had cancer in every bone in their body and were going to die next week. Nothing like that. Not anybody on hospice was revived by this. So the people that got it were men who had failed hormonal therapy for sure, maybe have no symptoms, but some of them did have mild symptoms. So in that group of men, it was a positive trial. Now on the plus side, I've given you all the negatives. On the plus side, it really may be a little better than I just said, because the way they did the trial was, the group that got the vaccine were given it immediately. The other guys, the control group, their blood was cultured, prepared, all gotten ready, and then frozen. But when their cancer progressed, they also got the vaccine. So it may be that, in essence, if there had been a control group who didn't get anything, maybe the difference in survival would be 6 months or 7 months. But that's the story. And then finally, when will this be available? Probably darn soon. The technique itself should be easily available in a place like Albuquerque if they can do what's called leukapheresis. But when it'll be up and running and so forth, I don't know. I have some patients I'm certainly considering it for. That about says it all, what do you think?
Thanks.
I also had a lot to say about chemotherapy tonight. How well tolerated it was. I should rush in and get it, but none of you are going to find that out.
I think our speakers will be willing to stay afterward and answer any of the questions if you want to go up. But please remember to bring in your surveys that in the back of your book. And thank you for coming tonight, and sorry for the technological difficulties.